Good morning. I am Amresh Tiwari, editor publisher of Double Helical. It's my kind privilege to host the today webinar, the very special topic prostate cancer. As you know that prostate cancer is a common disease for the middle age people. So in on this webinar we have the lot of eminent personalities as a panelist to discuss over the prostate cancer risk factors, cause and treatment. May I announce the name of those eminent specialists like Dr. Rajiv Sood. He is a senior urologist, vice chancellor, Baba Farid University of Health Sciences, Faridkot, Punjab. Dr. S.P. Yadav, he is a senior urologist, chairman and managing director, Pushpanjali Hospital, Gurgaon. And Dr. N. Srinath, he is a professor and HOD of Urology, Raja Rajeshwari Medical College, Pune, Bangalore, Pune, Karnataka, sorry, and is also senior consultant Apollo Specialty Hospital, Bangalore. And our one of the expert, public health expert, Dr. Amitabh Banerjee, is a professor emeritus, T.Y. Patil Medical College, Pune. And he is one of the best among very big personality in the medical frontier, like Dr. A.K. Agarwal. He is a associate with moderator and is already medical advisor, clinical research and innovation, Apollo Group of Hospital, and ex-Dean Maulana Azad Medical College. Now I over to Dr. Agarwal to host the webinar. Please. Dr. Agarwal. Dr. Agarwal.
Good morning. Good morning. Thank you, Tiwari ji, for as usual, wonderful start of a morning. And many mornings we hold this seminar on behalf of Double Helical, a magazine, health magazine, which has perhaps now completed more than 10 years and perhaps conveys relevant information on very important topics, not only to the medical professional, but to everybody, individual in the part of societies. And today the topic has been chosen by Double Helical is prostate gland. And to talk about prostate gland, we had very eminent medical professionals in front of us. I'll be talking to them one by one. And I'll start with Dr. Rajiv Sood. Dr. Rajiv Sood, can you hear me? Dr. Rajiv Sood?
Anji, sir.
Yes, great. So, friends, you know Dr. Rajiv Sood is a very eminent urologist, a person who established the urological services in central government health services, and he had been responsible for developing a wonderful department, Center of Excellence in RML Hospital in New Delhi. And besides his path-breaking research, etc., once he finished with inning with RML, he has been chosen to lead one of the very prestigious health university of Punjab, that is Baba Faridkot University of Health Sciences. And he is taking so many innovative first step, not only for Punjab, for the entire country. Welcome, Dr. Rajiv Sood.
Thank you, sir.
And I would like to start from you. The prostate gland, a very small gland. But sometimes if it is troublesome, then the life of a senior citizen, male senior citizen, becomes very, very terrible. So if I can say, even a smallest thing can create problem
Yes.
for you.
Yes, sir, you are absolutely right. This is a small gland, but a big problem. And we realize it, I think in US in
Yes.
2003, when it was realized, and one president of US has issued that declaration that this has to be. Colonel Powell was there who suffered from it, and it became the awareness point. And we were not very behind in India. In 2007, we started the pilot project in Delhi. Initially, then the North India, and then the entire country prostate disease awareness program. And this was highly successful program. And in this, we wanted to know what is the exact incidence of and prevalence of prostate cancer. I will only mention that roughly as per age, if we are 80 years of age, then 80% chances are there that there are cancer cells in the prostate. And if you are 50 years, then 50%, and 100 year in autopsies, almost every prostate will have cancer cells. So initial craze of screening, public screening, which was prevalent in US, led to many prostates sacrificed. And population was moving around without prostate, and with the complication. So later on, the whole concept was changed, and high risk patients and symptomatic patients only, we started the screening. What happened in 2007 in India? We verified it, and we only screened the symptomatic patients for prostate cancer, especially with digital rectal examination. And it was the cheapest way possible to diagnose on PR the suspicion of prostate cancer. And if you are suspicious or high risk is there, our extended arm of examination, ultrasound, was applied, and wherever required, the biopsy was done. PSA is not used as screening, and PSA is done only in the suspicious cases, because PSA is relatively not cheap for screening. And I'll set the context in the direction that ICMR projects like Atlas projects and all, which are running for various cancers like breast cancer or cervix cancer, cannot be applied on prostate, because it is very costly affair. And therefore, this was adopted in that way. And accordingly, we have now adopted. And you know that in Ram Manohar Lohia Hospital, we designed the screening formula, yearly screening protocol for all the IS and other senior officials, and that is followed till now. But unfortunately, initially when we designed it, PSA was part of that screening, and that is still continuing. Anyway, it is not revised till today. And whatever we are doing, now the common understanding is that PSA screening, if you are doing or you can afford, it should be up to the age of 59 in asymptomatic, and not beyond that. At least digital rectal examination should be done. And why it is important? The prostate cancer incidence in India is low compared to US. But the advanced cancers, maybe because of the late diagnosis, or maybe because of the nature of the disease, they are the metastatic prostate cancers in India are equal in number to USA. So you can understand what is the financial burden and what is the effect on GDP. So these are certain things which I wanted to share with
Thank
you.
you. Thank
But
you,
one
Dr.
thing is
Rajiv.
there, that when the boy is born, 13% cases, cancer cells are since birth, and they become non-symptomatic throughout life.
Thank you, Dr. Rajiv. I think before we jump over to prostate cancer, please allow me, and I will like to comment of my all expert panelists in front of me. We'll spend little time on benign enlargement of prostate. because this platform is for the public and public at large, whosoever will be hearing this video will like to know something about the benign enlargement. And I would like to request Dr. Yadav.
Sir?
Dr.
Sir.
Yadav, can you hear me?
Yes, sir.
Thank you for joining us this morning.
Thank you, sir.
And as regard your observation is concerned, at what age we are perhaps mostly seeing the benign enlargement of the prostate? And what are the commonest symptoms?
Sir, nowadays we call it LUTS, lower urinary tract syndrome or symptoms. After the age of 50 or 55. Hello?
Yes, sir.
After the age of 50 or 55, patient usually notices that his frequency at getting up at night to pass urine has increased. His stream has gone down. He has taken a longer time to pass urine. For example, he goes to toilet, common toilets in the railway station or picture halls. Some 1 or 2 young persons have gone out and he is still peeing. Then he realizes that time taken to pass urine is more. Recurrent urinary tract infections. Sometimes the complications of the BPH means significant retention of urine. Normally, when we pass urine, when the young person passes urine, the amount left after passing urine is almost nil in young age group. But as the age passes and reaches 50 or 55, above 50, the amount of urine passes leaving behind in the bladder gets 30 ml, 40 ml, 50 ml. So then he realizes that there's something wrong with him. So
Dr. Yadav, when we were a student 50 years back, I remember our casualty was full of urinary retention, and then we used to do suprapubic cystostomy, and very often.
Yeah.
Nowadays, are we seeing equal number of cases?
No, sir. Nowadays, things have changed with the reason that the people have become more aware and the medical treatment has come up, which is very good. In the first 10, 15 years, earlier when we were students, I was student MBBS in 75. You must be in 70s or 60s. Yes,
60.
then the medical treatment was not available. Ultrasound was not available. Patient was not aware. So now when the patient feels that he is not okay, he sees the physician rather than seeing a urologist. And the physician says that your post-word residue is significant, 50 ml, 60 ml, 70 ml. So he normally suprapubic cystostomy is almost obsolete nowadays.
That's right. So I thought, Dr. Sood, Dr. Sood.
Dr. Sood, you are silent, you are mute.
Dr. Sood, can you hear me?
Dr. Sood, you are mute.
Dr. Srinath?
Yes, sir.
Yes,
Good
sir.
morning, sir.
Good morning. Good morning. Thank you for. I know Dr. Srinath is professor in one of the very prestigious college just outside the periphery of Bangalore. If you go from Bangalore to Mysore, the first one of the very important building on the highway is your medical college, and you are
Yes.
also
Yes, sir.
associated with Apollo Hospital.
Sir.
That's so wonderful to have you. Yes, my same question as I asked Dr. Yadav, the previous scenario versus the present scenario as regard the urinary retention. You also agree with him that now we do not get that acute cases as we used to get earlier.
Very
Your-
right, sir. Very right. So we have to realize that there are two entities, one benign, one malignant, which are very common in elderly males. Both these affect elderly males and both at the same time. And most often, even when there is a cancer prostate, the benign enlargement of the prostate is always there, associated with it. So the symptoms initially will always be because of the obstruction only. Earlier, what used to happen, there was no medical treatment for the LUTs to improve the flow as well as the decrease the frequency, because flow problems and the storage problems are the main issues. Now we have got better treatment, medical treatment available, so the chances of patients going into retention are less. So that is one thing. That is why the retention is less common nowadays, because the good medical treatment is there, and the number of patients undergoing TURP or surgery for BPH has also fallen down very much since we did our MCH, and now there is a very drastic fall in the surgical this thing, because a medical treatment is available for the symptoms arising out of the prostatic enlargement. One is a benign prostatic enlargement, that is BPH. So most of the times we are not operating now, and the incidence of retention has also come down to a large extent. And most often we can get away with a catheterization only, even when you have a retention, and the SPC is usually not required.
Thank you. Thank you. Dr. Banerjee, you are the expert of public health. And in any particular area, your public health experience, as Dr. Rajesh said in the beginning, prostate problem is not a problem where we are talking about individual a small number. It is so big that one can always think it's a big public health problem. What figures Dr. Rajiv Sood gave me just now, 15 minutes back, my God, it's such an important public health problem that we must do something. Uh, Now, from your experience as regard the prostate in rural India, my expert says that now there is medical treatment, awareness is there, and that is why we are not getting that acute condition. What is your experience as a public health expert? Are we getting the same picture in rural India also? And how much is the awareness of public as regards the preventive care of prostate enlargement?
Thank you, Dr. Agarwal. Actually, rural areas also, I don't have immediate first-hand experience, because in our medical college, we have a rural health center where we have got visiting doctors going there and running OPDs. So exactly we don't know. But I think even the rural people also have access to model medical treatment. Either they report to their primary health center, or they are referred to the district hospital.
It's a good news that our even the rural population is having
From
access.
rural, we do not get like we are holding camps in the rural area and bringing to a medical college, but we are hardly face any acute retention where we have to go for that suprapubic drainage. So I think catheter and all, as Dr. Sina said. So we don't see, at least I didn't see, I can say as a primary care physician, because my limit is at the OPD level. So I don't think, I think they have got access to the emergency management.
That means in last few decades we have really developed our system so well that this common condition is being taken care of right from the beginning, and then perhaps the severity is also controlled. And Dr. Sood,
Sir, yes, sir.
yes, so we were discussing that benign enlargement, or forget about benign. Once you get a patient with urinary obstruction, with the same typical history, that acute retention and previous history of more and more retention, recurrent UTI, the common conditions you think in your mind either benign or it can be a cancerous prostate,
Sir,
right?
it depends on
Beside
the
infection.
age, but
Yes.
yes, benign is most dominating condition, and we call it as a syndrome. It is lower urinary tract syndrome, which include every possible cause of symptoms, common symptom complex, which can be because of BPH, because of even CA prostate or prostatitis, or even bladder conditions. So these common conditions, which are lower urinary tract symptom, once reported, then we go for further investigation, and depending on age, like 40 plus, we suspect BPH, benign enlargement, and if the patient is on the higher side of the age, it can be cancer. So today's webinar was on prostate cancer. Therefore, I started with that figure, but yes.
Absolutely fine. We are coming to that. We are absolutely
Okay,
coming.
now the prostate, as has been discussed, what is the problem in the rural and urban divide? It is very clear that before 1980s, it was only open surgery available in India, and we were going for SPCs, we were going for this catheterization, and not only that, even open surgery was two-stage surgery. Once we were in one stage, we were taking to operation theater, removing prostate, packing the fossa for preventing the bleeding, and then again we were taking the patient to the theater. So these all condition has evolved, treatment has evolved, and today what is happening when you are talking especially on urban-rural divide, I'll share with you that the most common cause of the kidney transplant need or the obstructive uropathy in India still in the rural area is prostate. So prostate is not simple. It is in the far reach areas, rural areas, negligence, awareness lacking. Our problem is that people are losing their kidneys because of the chronic obstructions. So this is very important. When I was talking about when early days, maybe 4 to 5 decades back, people used to wear hat, and in the hat they used to keep the catheter, and that catheter, the old people, they used to lubricate with the saliva, and they were self-catheterizing. So from that we have started, and now we are in a position that there is a divide, rural-urban divide, but condition is quite better. 80% of the patients are on for BPH, benign prostate. They are on medication, and you have to earn your surgery. It is not that every patient is going for surgery, and surgery is now minimal invasive. And patient may be discharged, if not same day, the next day. So this is so much improvement in the as far as benign prostate enlargement is concerned, which is a part of overall complex of LUTS, that is lower urinary tract syndrome.
So we will come back to you, Dr. Rajiv. Now we are talking about the suspected condition of prostate cancer. Once symptomatology is there, the patient will come to you and you will suspect urinary cancer, right? So, Dr. Yadav, what is going to be your first approach? You are suspecting urinary cancer in a male patient of 70 years.
Why I have suspected, sir? On examination, on investigation,
फिलहाल तो symptomatology basis.
symptomatology.
अभी examine आपको करना है.
हाँ sir. Symptomatologically, patient comes with the routine lower urinary tract symptoms like bladder outlet obstruction, significant post-bad residue, all LUTS symptoms as in the BPH. There is hardly any change in the symptoms of BPH and the CA prostate. But on examination, particularly on digital rectal examination, DRE, which is very important. Nowadays, people have forgotten, but it is a very significant investigation. The moment we put our finger into the rectum to feel the feel of the prostate, 50% of chances that we can easily diagnose a case of CA prostate. The clinical examination, 1. 2, the ultrasonography. The ultrasound sonologists tell us what is the status of the prostate, it is a benign, or 2, say this texture is changed, any significant residue leading to back pressure changes, what the size is there. 3rd, the PSA. PSA has significantly changed the whole scenario, as Dr. Sood has said, in the last 15, 20 years. I remember in 1994, sir, in 1994, I was in USA in California, the Catalona. The man was working on the PSA. He was initiating or doing the PSA at that time in 1994. In India at that time, PSA was not available. But you now see every physician, every GPs are doing the PSA after the age of 50, 60, whenever a patient of BPH goes to them. So the first is history. Second is the examination by digital rectal examination. Third is the sonography. Fourth is the PSA. And once PSA is high, rectal examination shows there is a nodule or there is a consistency change. The PSA is done. PSA is high. Normal PSA as you know, we all know, 0 to 4 is taken as normal at the age of 50.
Here, I would like to, sorry, these normal parameters which belongs to Western world, has it been standardized as regard Indian population is concerned?
No, no, sir. Is very sorry, honestly speaking, very sorry. The still the parameters of the questions we are following them.
Dr. Srinath, your comment?
Yeah. See, there has been a study by Apollo Hyderabad and Apollo Chennai, in which they studied a large number of patients who underwent PSAs during a retrospective study, and they have found out, they have calculated what is the percentile of patients who are in different age groups. This is the best study we have got for the PSA levels in India. They have said in different age groups what is the 95 percentile of the patients who are having the PSA levels. That gives rise to some amount of thing what is happening in India. Usually the PSA cutoff levels are a little lower in India compared to the West.
Okay. So, Dr. Rajiv Sood, coming back to you. Dr. Sood? Dr. Sood?
Sir, please unmute.
Anji,
Yeah, yeah.
yes, sir.
Yes. We are talking about the value of PSA as regard Indian standards are concerned.
Yeah.
We have, so far, we have
Initially, I
adopted.
mentioned that PSA, there are two scenarios. One is as the public screening. The second scenario which India has adopted is symptomatic and high risk patient screening. And PSA, before PSA, most of the patient, 95%, were diagnosed as metastatic. And in US, when PSA is prevalent screening, only 5%. So huge gap was there. And therefore now around 30% are early diagnosis. In our case, still we have not reached the figure of 95%, which is in the advanced countries. So PSA screening, which we are doing in the symptomatic or high risk, we are not doing enough because of lack of awareness. So our main problem is awareness in India, and PSA has great value. It is not the diagnostic, but it definitely it gives you the suspicion of increase, because there are other conditions also where PSA can be raised, which may be the very large prostate, or maybe prostatitis, or maybe catheterization, which will increase the PSA value. And sometimes if the PSA sample has been given after urethral manipulation or maybe ejaculation, then also we can find PSA more. So, or maybe sometimes stone or passage of stone. Whenever there is a insult in the prostatic urethra, then PSA value may be raised. So we have to watch. It is not one PSA is important. If such history is there, we repeat PSA after 2 weeks. Or in US and other countries advanced, they say antibiotic has no value. But in India, where there are studies from my hospital, RML, SGPGI, Lucknow, and PGI Chandigarh. And it has been found that because of the tropical nature of our country, the PSA may be raised, and they have found that by giving the course of antibiotic, which is not in the guideline, sometime the PSA comes down. We are regularly giving, therefore, in Indian conditions. And if PSA is coming down, we watch. Otherwise, we go further for maybe ultrasound and, if indicated, the biopsy. And if persistently PSA is high, then we go for transrectal or transperineal biopsy. So these are, but before that, there is a situation, imaging is to be done or not. And some studies say that MRI should be done. That is the best, if available and affordable. Maybe after, before the biopsy even. So that gives us a specific scoring. And on MRI 3 Tesla high resolution, we can suspect very, very narrowly that there can be cancerous cells in the prostate or nodule. And therefore, PSA has great value, not only for the diagnosis, and if by chance the cancer is suspected or is diagnosed, as a follow-up also. So this is a very important tool in the basket of urologist.
Thank you. I think after listening to all my urologists, can I go back to my public health expert, Dr. Banerjee? PSA, I'm talking of public health point of view, the screening point of view. So, and we did discuss about the status of values outside in India versus India. Your observation regarding PSA is an important tool for screening?
Thank you, Dr. Agarwal. PSA as a screening tool in the general population, asymptomatic population, has a lot of pitfalls. Particularly like in Western countries, the incidence and prevalence is high of prostate cancer. So there the false positivity rate may be low, but in a population like India, the false positivity is up to the level of 40 to 60%. And the false negativity is also almost 25%. So it is not a good screening.
Rajiv has already described many other conditions which may affect your PSA.
So therefore, it is not a very good, because unnecessarily it will increase the cost, it will increase the anxiety, it will lead to unnecessary procedures. So it can be restricted as a tool with clinical examination and biopsy and the symptomatic cases, particularly direct rectal examination or biopsy. But asymptomatic, it is not a very good positive predictive value or negative predictive value. So it is not cost effective, and they have done studies. So to catch one positive case, you have to screen 700 healthy people. So it is not as effective like cervical cancer screening or other screening. So it is they're not recommended as a public health screening tool as on today.
So after listening all this expert opinion, yes, I'll come back.
I want to comment one thing about PSA.
Yes.
As that Sood has said, PSA is not only an investigation for CA prostate, prostatitis, acute retention, catheterization, so many things. Sir, routinely I am seeing in my clinical OPD, a patient is being trapped by the PSA. Retention, patient comes with a fever, dysuria, burning sensations, and routinely after the ultrasound, a physician advises PSA. PSA is 7 or 8 or 10. In prostatic abscess, I have seen up to 400. Then what next? Patient gets MRI done. What next? Patient gets biopsy done. What next? Biopsy comes out to prostatitis. So patient is, honestly speaking, is trapped into the PSA in those conditions where it was a normal. As in case of simple UTI, prostatitis, catheterization, acute retention. It is very common in general practice that in all these 3-4 conditions, PSA goes up. And a general physician or a general surgeon puts a catheter get the PSA done, his PSA is high, he gets the MRI done, then PSA is high, MRI is not, as honestly speaking, well read. It's a radiologist, is the person, radiologist who tells us, then a biopsy is done. When the PSA was high because of the prostatitis, patient had to undergo MRI, biopsy, and 2-3 months he's trapped. I have seen not 1, 2, 3. I have seen 15 or 20 patients the last 3-4 months only. Very VIP patients also. So this was just an information to the common man that single PSA report, PSA with fever, dysuria, burning sensations should not be taken very seriously. It should be followed up in next 2-3 months, how it turns out to be.
Sir. May I speak, sir?
Please, sir, mute, sir. Dr.
Yeah.
Agarwal, please mute, sir.
Then
Yes.
I wanted to
Yes,
tell
yes.
something. Yeah, see, very important that whenever a patient comes with retention, don't get the PSA straight away. Always get it after 4-5 days. Many a times it will be normal. By the time you will come to know whether he has got a prostatic abscess. Another important screening we should do in targeted screening need to be in high risk patients. For example, persons having their parents or the brother or first degree relatives having prostate cancer, they are at risk for prostate cancer. They should be screened. And also many syndromic cancer things like BRCA1, BRCA2, if breast cancer or endometrial cancer is there in relatives, first degree relatives, then again screening should be done. These are small populations. However, if that history is there, they should be screened.
Thank you. So coming back, but now we are going towards confirmatory diagnosis. And as has been told that besides all the blood tests, etc., ultrasonic investigation and MRI plays a very important role. But you think that ultimately the confirmation has to be by biopsy. Is there any doubt?
No doubt.
No.
No
Okay.
doubt.
No.
Now, when we come to the biopsy confirmation, as a non-urologist, I understand now most of the time our urologist colleagues are going through transrectal approach, what you call TRUS, and recently few of the urologists has adopted peri
Perineal.
Perineal, transperineal.
transperineal approach. So what do you think your opinion is? I understand both the approaches are, depends which approach you want to do. But I would like to know from my 3 urologists, what is the best for the patient? Rajiv.
See, this is very important question, and I think most relevant, because as you have asked and we have discussed, the biopsy is the final diagnosis. All other ways like pirate scoring on MRI or maybe even PSMA, PET scanning, they are the suspicious things. But confirmation is always histopathological. And now how to get that sample? There are 2 conditions. Either there is a nodule or there is a lesion, or sometimes we don't see the lesion, but there is a suspicion because of the PSA, very high PSA, and even pirate scoring we are not finding. There may be more than one lesion. There is conventional biopsies where we take the cores from different areas of the prostate, and there is a standard template that 16 core biopsy we do. But there had been saturation biopsy 32 core or less. If it is clear-cut case of hard nodule on digital rectal examination, then we can limit it to the blind biopsy also, just for diagnosis if metastasis and all is there. But now coming back to biopsy, biopsy is ultrasound guided. It can be transrectal, where you know that the rectum is in, we are going through the rectal skin, and transperineal is theoretical also, and otherwise also the best, but is a more demanding. It has to be learned now because the prostate cancer, the perineal way of the templates are available, and we can take the biopsy, we can do that prostate cancer treatment. Same templates or similar templates can be used to take biopsy. And in biopsy, one is ultrasound guided, simple, or there can be the biopsy, which is fusion biopsy. And now there are various ultrasounds and various semi-robotic equipment has come where we can fuse the MRI images with the ultrasound images, and cognition is there, and we can take the biopsy, a general template of 16 core plus the suspicious area. So biopsy is very important. Perineal is better than transrectal, which is more demanding procedure wise, and we can target difficult areas and also the suspicious areas if we have readily available MRI images with us. Sir, you are mute.
Dr. Agrawal, sir, you are mute.
Thank you. I think I was going through the literature, and your colleagues from United Kingdoms are very keen for transperineal biopsy approach.
Yeah.
Am I correct? And perhaps in India also. But I agree there is a very big learning curve before you go for transperineal biopsy. And of course, for urologist, it is you are playing with your own playground, so that should not be a problem. But MR fusion is perhaps there for precision, for accuracy. But many a times I find the availability of MR fusion biopsy. Your comment, Dr. Yadav?
Sir, it is not only the availability, it is the training also. Honestly speaking, in Gurgaon, we have 4 or 5 big corporate hospitals. There's hardly 1 or 2 person who are doing it. I know the Fortis, Medanta, Artemis, Paras, Max. Everybody says that we are doing MR fusion biopsy. Honestly speaking, it's off record, I am telling you, but there's hardly 1 or 2 person who can do it or who are doing it, because we are not trained into MR fusion biopsy. We are only trained into ultrasonography and rectal biopsies. Maybe the younger generation, maybe the institutes, or even my son, who is a associate professor of urology in Safdarjung, he says we are also not very much trained. See, honestly speaking, the fusion has come up recently, so only 1 or 2 people are doing the fusion biopsy. Rest are trying in the ultrasonographic guided.
But you
MR
agree
guided.
that it will improve the outcome?
Agreed, sir. It will
So
be more
then it is
specific.
okay. I mean, if it is better, then let us try to make our youngsters learn
Yes, sir.
more and more.
Yeah, youngsters are doing it and they are trying to learn it and doing better in the coming future. And the number of core biopsies will definitely reduce. Now we are raising from 16 to 36. Why? If you know that's only in the right lobe, that too in the apex, why to take so many biopsies? Why should not be specific after reading the MRIs and making it a fusion, and just specific 2-3 areas particularly?
All right. Dr. Srinath, your experience?
See, you should remember that it is like an orange. Inside orange, there are a lot of seeds. One of the seed is a cancer, and you have to take specimen from that cancer. That is why you need a lot of guidance. Where exactly is that cancer? So that is where this MP-MRI or multiparametric MRI comes in. So that will tell you which are the areas where are very much apt, likely to have cancer. So MR fusion, since we are already doing truss, if you are doing a truss properly, because this image is laid on the truss image, and it will show you where is the thing, And then when you are doing a truss, you can see the needle going through the thing and come out. So it can be done. But of course, the thing is very costly and not easily available. So all these things comes important when rectal examination is normal, PSA is high. You do not know exactly where is the so that is where this MPMRI and fusion biopsies are very much helpful. But even spite of that, you may end up not getting a representative sample. That means all the samples may not have hit the cancer. At that time, if the persistent PSA is raised, you may have to go in for more biopsies, saturation biopsies, so that at some of the things. Another important thing is, if MPMRI is positive, should you not do a systemic biopsy? There are a small percentage of cases which may not be very significant, which will be missed by MRI. So systematic biopsies also will have to be done. At present, we are doing systematic biopsies also, even if there is a MRI indicated region which is probably having the cancer.
Dr. Banerjee, as a public health expert, your target will be public screening besides symptomatology or whatever we have discussed. But what is the role of, because cytological examination is the commonest thing one can take up. We like to comment upon it, that the routine cytological examination of urine, does it give you some clue?
I
Rajiv?
don't think in prostate cancer, I think urologists would know better. But
Rajiv?
See, there are.
I'm talking of public
Yeah,
health.
I know, but they are very costly. One, the urine PC3 testing is available for the cancer cells in the urine, and it has not become popular, though it is available for last almost 15 years. So cancer cells in the or the diagnosis through urine examination is possible in prostate, but it has not been adopted widely. It is not that accurate also, and but possibility is there. It can be done.
Right.
But it would
Now
be
I would
very
like to
costly, sir. It would be very costly if you go at a general public screening. It is not
agree.
Yeah,
cost
in that
effective.
it
Public
is not
screening means
adopted, and it
cost
is very
effective.
costly.
Only
Because
high risk with a age, elderly people with a family history, genetic history. Only I think that would be better
no,
at the
actually,
medical, at
if
the clinic.
I'll tell you, if the PSA is in the gray zone, then only this testing in the urine had been recommended when it was FDA approved. But it is not adopted because it is very costly. Any screening tool has to be cheaper, and we will not be able to ever, in the current scenario, adopt this unless it becomes very cheap. So, and it is not for every patient. It is only for PSA ranging between 4 and 10.
So my next step will be, once all of you have diagnosed cancer of the prostate, what next? There is a probability of surgical intervention. There is a probability of some sort of radiation or chemotherapeutic or other kind of drug. Rajiv, what
Then
is
once
your
the
experience?
prostate cancer is diagnosed, then we have to see that what is going to be the behavior, and the behavior of prostate cancer. It can be aggressive cancer. It can be the less aggressive. Gleason scoring is important, and whether it is which category of Gleason score is there. It goes up to from 3+3 to 5+5. That is 10. This is the range of Gleason score. Higher the score in the histopathology, the more is the aggression of the prostate cancer. And other thing is that we have sometimes 3+3 is there, but it is only on imaging. It is not the exact pathological staging. So unless we do the prostatectomy, we will not be able to find out the pathological staging, and it will be the clinical staging only. And therefore, there are two terms are there. One is the watchful waiting. Once you diagnose, and if the PSA is high and you are not finding the prostate cancer cells, then either go for repeat biopsy, even then it is negative, then active surveillance. Active surveillance, when you can follow the patients. And another important thing is that is age, life expectancy. If you have 10 years expected the person will live, then only we go for aggressive treatment. Otherwise, we don't go for surgery. The second option is the best is surgery, the total removal of the tumor cells. The second is the radiation, and that can be adopted. Now it is image guided and IMRT, the image guided, or this can be safe for the neighboring organs also, like rectum and all. So radiation delivery is improving, and then we can implant the seeds also in the prostate. If the diagnosis, and we were discussing about the perineal route, through perineal route, the radioactive seeds we can implant. So it depends on the expertise of the treating urologist or radiotherapist, and also the consent, which kind of consent the patient is giving. We give them option of surgery or radiation. Sometimes patient is not willing for surgery and they opt for radiation. So this all depends that what next is decided by the aggressiveness. If the family history is there, we don't take chance. Because the chances of aggression increase. So various factors are there which are to be considered, and nowadays it is individualized treatment. It is not the general treatment. Our guidelines are also now changed, and each patient is different. It is not the disease we are treating the patient, and we have to tailor our treatment as per index cases which are quoted in the guidelines.
Thank you. Thank you, Dr. Rakesh. Dr. Yadav,
Sir,
you just
Yeah.
now heard Dr. Rajesh
I am
Sood.
picking up Dr. Sood's last comment, that the last statement, that it is individualized treatment, because the treatment, in my opinion, depends upon the age. If the patient is diagnosed at the age of 50, his treatment is different. If diagnosed at the age of 78, his treatment line will be absolutely different. Because in 78 or 72 or 75, and depending upon the grade of the tumor, if it is 3+3, it is better to watchful watching or surveillance every year for 2, 3, 4 years, and then you tailor it by repeat biopsy or MRIs, depending upon the grade of the tumor, stage of the tumor. If he comes with the metastasis, treatment is different. What is the comorbidities? As a statement has been made by Dr. Sood also, that if life expectancy is 10 years and he is 72, 73, it is better not to put him in a very aggressive treatment, rather to put him on a simpler treatment where there's less complications. And last of all, I would like to add the financial status of the patient in India. I am living not only in Gurgaon, I am working in Rewari, which is very sandwiched between the Rajasthan and this Mewat region, where people don't have much money, honestly speaking, don't have much money. They don't have money to even to take medicines. We do to ERP, the biopsy report turns out to be the CA. We tell them, get this MRI done, this done, bone scan done. They say, we don't have money. For them, in my opinion, treatment line should be like this, that we can give them 10, 15 years of life with every 6 monthly or 1 year simple follow-up. So in my opinion, sir, treatment should be individualized depending upon the age of the patient, grade of the tumor, stage of the tumor, comorbidities of the patient, that means life expectancy of the patient, and the financial status in our country also.
Thank you. Dr. Srinath, what had been your experience?
So, see, the thing, even now people come with advanced disease, What we are talking here is we have been able to catch the thing in early. See, this will occur most often when the PSA has been done. So nowadays in cities, most of the men's checkup, corporate checkup will have PSA, and they will come with the PSA. However, all the guidelines say before doing a PSA, you should be a shared decision making. If you are doing the test, you will have to tell him what are the consequences of this test. What if it becomes high? What are you going to do? What are the steps you will take? So these patients nowadays, the earlier problem was if it was a very early disease, the treatment may be more, the effects of the treatment may be worse than the disease. That is no longer true now because of our improvements in the surgical technique with the laparoscopic radical prostatectomy followed by robotic assisted laparoscopic radical prostatectomy. The adverse effects of the surgery are much less reduced, and radiotherapy has also improved. So definitely we can offer them a good treatment even if we catch them early. So, and we can offer them a really long disease-free life once we do the early cancer, prostate cancer treatment. So, but yes, definitely. But with the Ayushman and other things coming up, many a times laparoscopic radical prostatectomy can still be done within the that scope. However, yes, definitely the cost is a major factor.
All right. I think time is approaching fast. We are going to complete 1 hour. But before that, I am going to request all of you to give 1 minute comment. Because one thing is definite that is CA prostate is not rare. It is a common condition. And the treatment, the entire process has become so advanced that we are able to pick it up, and the awareness among the patients have definitely increased. So what is the message from Dr. Rajiv Sood for the society from your side?
For the society, the awareness is the foremost, and for awareness, we have to do the drive, and we should not ignore our symptoms, and these symptoms are to be reported immediately to surgeon or urologist, and the distal rectal examination is best for initial screening or suspicion, and we should understand that that treatment is to be initiated, and it can cure, total cure, and this is the only cancer in the body which is amenable to surgery, radiation, immunotherapy also now recently, and
Yeah.
also chemotherapy, second line chemotherapy. So, and also anti-androgens, hormonal therapy. So there are very a few cancer. One is prostate, the breast also in female, which we are exploring all possible modalities. And individualized treatment is the key, and we should concentrate for our rural population, because it is damaging. If neglected, can damage our kidneys also.
Dr. Yadav, your message to
Yeah.
rural population.
So my message to the population is number one, do not get disturbed by the raised PSA and the diagnosis of the cancer of the prostate. It is not, people come to us that my PSA is high, I'm having cancer, what is my life expectancy? I always tell them, and the message, I want to give a message to them and reassure them that this is one cancer where you can have a sufficiently long time even without treatment, without being in such a hurry. People come, my PSA is 7, my PSA is 10, don't get upset. Just see your urologist. Get yourself again reconfirmed it, whether it's PSA high because of the cancer or because of other things. Don't worry about the life expectancy is too short. No, this cancer is, honestly speaking, is not as bad cancer as people are being told of. So my message to society is, please do not get so much upset with the raised PSA and the diagnosis of the cancer of the prostate. Get yourself proper treated. You will have a sufficient good life and healthy life.
Great. Dr. Srinath,
Yes, sir. So there is a
bullet message.
prostate awareness month in November. So usually we do a lot of activities during that period, and this is definitely helpful in doing that. But one should be very clear: all this good treatment and prognosis is there for confined cancer. If you have metastatic cancer, it can be bad, and the outcome is not that good. Of course, there are a lot of treatment available. So the idea is to catch them early and treat them. Thank you.
I think Dr. Amit Banerjee, last word from you.
Yeah, I think something unusual is happening as it was brought out in Asia, particularly India, the prostate cancer was much lower, 10 times lower than the Western countries. But for the last 3 decades, in 1990s, the incidence, the number 3, it was number 11 among all cancers. Among all cancers, prostate cancer was at the rank of number 11, and today it is at the rank of number 3 after oral cancer and lung cancer. India number 1, oral and lung cancer number 3, whereas in 1990 it was number 11 among all cancers. So we cannot attribute it to increased detection because it would have affected all cancers similarly. So something unusual is happening, and then there are some global patterns like Western countries, the prostate cancer is high, but it is very low in China and Japan, particularly Japan. Japan has got one of the oldest population, so they should have had a high prostate cancer. So we have to do more research whether it is obesity because Japanese are not as obese as the Western population, or are we becoming more obese? There are no direct preventive risk factors which are well established, but there are indirect evidence that they may be related to obesity, BMI, may be related to dairy products or high meat diet or alcohol and smoking. Of course, they have no strong evidence. We require more research. Anyway, in the interim, people should follow a healthy lifestyle, control their weight. That's all we can offer as on today, as far as prevention is concerned.
So, Dr. Rajiv, and Dr. Banerjee has given a big challenge to you as Vice Chancellor of one of the very eminent university. And why it is increasing? It is something from 11th position, it has come to third
Yes, I am
position.
quoting from Indian Journal of Urology, July, September.
I fully agree. I fully
So
agree.
it is their journal
So
because
it is up to
Okay.
our clinical
So I'll,
colleagues
I'll,
to.
I'll give a brief comment on this that our lifestyle important,
Yeah.
our lifespan, which is increasing, and that is why the incidence is increasing. And also our metabolic syndrome, it has been found that obesity or other components of metabolic syndrome expose it to the prostate cancer precipitation, clinical precipitation. And it is in any inflammatory disease. Obesity is also one of them. This cancer is faring bad, and therefore we should be careful about our diet and our lifestyle. And green vegetables, fried food, fast food is to be avoided. So these all diet is also important, and antioxidants in the diet are important. Lycopene and all, we know that there are certain components in the diet which are concentrated in urogenital system, and they are antioxidants. So it has been now mentioned that if we consume the fruits and food containing lycopene, like tomatoes or the concentrates of that, then the cancer becomes low. And there, the countries where the tomato sauce is consumed a lot, or certain lifestyles are there, their cancer is less in that. So various factors are there, and we have to be careful. Yes, as the university, the responsibility is for the universal tackling the condition. And I will only say to the fellow urologists also, and all the institutions, that prostate disease awareness program spearheaded by Urological Society of India has given us a way, and that really increase the awareness. And awareness programs, especially for the rural India, are important.
Thank you.
Now I will hand over to Tiwari ji, the mastermind behind this webinar. I'm sure there may be, तिवारी जी एक एक क्वेश्चन ही लीजिएगा, ज्यादा का टाइम नहीं है.
Yes, sure. Okay, sir. Thank you. Don't worry. Sir, this question directly goes to Dr. S.P. Yadav. My friend, one of the Dr. Anand, he's my friend from Ambala. He's asking, should we screen for PSA in all the older people with BPH? How frequently? What is the sensitivity and specifically of PSA?
All the patient BPH who come to the urologist, medico-legally as well as otherwise also, PSA should be done.
And next question goes to Dr. Shud. Sir, could you tell us what role does genetics play in prostate cancer? And should family members get tested? What do you say?
If the prostate cancer is there in one male member, the chances of the second male member getting affected goes by 2.5 times. And if two members, male members in any family are affected, then the incidence goes by 7.5 times. So definitely, if or any other cancer in the family, there also the incidence increase. So if the family members are involved, then it should be done the screening. And the second thing is, if the prostate cancer is on the higher side, there are certain tests like BRCA test and all which are available. They are costly, but if the can be afforded, they can be subjected to. High risk cases should be subjective. Aggressive cancer should be subjective, because upfront we know that what kind of medication will be effective in such cases.
Thank you, sir. Next question goes to Dr. N. Srinath. Sir, could you tell us how does prostate cancer impact sexual health and overall quality of life? What would you say, sir, please?
Sexual health per se does not cause any problem, but however, there are a lot of sexual issues which can be there in elderly persons, and like erectile dysfunction and all, which may or may not have anything to do with the prostate cancer as such. However, the treatment of prostate cancer may give rise to some problems in the sexual thing. For example, there will not be any ejaculation after the surgery, and erectile function also may be affected post-surgery. Even after radiation also, there can be some differences in the sexual function which may develop as part of the treatment.
Thank you, sir. And the next question goes to Dr. Amitabh Banerjee. Sir, from public point of view, could you tell us, can a man live without prostate? And second, how long can a man live with prostate cancer?
This is very interesting. Actually, when we were in college, they found above 80 years, many people died with prostate cancer of autopsy without any symptoms. So cancer has got a very complex and uncertain natural history of disease. So I think it is still debatable. Some people may carry the cancer to their grave without any symptoms, and in some it may be aggressive. So I think it is for the pathologist and the urologist to follow and have a proper research. So I think it's I mean, as far as we are concerned, we cannot really predict which will be aggressive, which will be, I mean, the urologist, some of the urologists can take it on from here, because I don't know what happens after they are.
I think Dr. Rajiv in the beginning did say 100 years, 100% chance.
See,
Is
the biology of the tumors are different. There are some tumors which are of lower biology. They grow slow. They are the ones which they go to the grave. But there are some cancers, even in a young person, it can be very galloping, very fast growing cancer. The biology is different. That is why nowadays we are doing molecular testing for all the cancer, the tissues we take out, molecular genetics, we go into that. And those cancers which are showing faster growth rate with greater molecular changes in the genetic makeup of the cancer, they will be aggressively may have to be treated.
Dr. Yadav would like to comment, please.
Please, sir. See, the tumor, as one thing I want to say, that if the patient is 50 years and PSA is 1, At 55, his PSA is 2. At 58 to 59, PSA is 3. He is definitely harboring a CA prostate inside, even if the PSA is less than 4 or 5. After few years, definitely, this is one thing, one comment I want to make, that anybody where the PSA is rising every 3 year, 4 year, one must be very sure that after 5 to 10 years, there is some focus of the CA prostate inside his prostate. This is one point. Secondly, again and again, I am telling you, it is the age of the person, it's the grade of the tumor, it is the state of the tumor, the stage of the tumor, the comorbidities, life expectancy, and financial, all should be taken care of before giving a final treatment. If a person who is not having anything to eat, and I advise him robotic radical prostatectomy, no, honestly speaking, no. Same way, we should try to devise the treatment in view of his financial statement, status, age, and grade and stage of the tumor. And one should not be worried of it too much.
So
Okay, sir. Over to
at
Dr.
the
Agarwal,
end,
sir.
yes, sir. At the end, I will like to give one important comment that perhaps the last 1 hour discussion has raised certain queries in the mind. And it seems that the problem regarding prostate, especially being malignant, seems to be very high in number, but God is kind enough to make that it remains asymptomatic. But one has to be careful. The alarming signal that in India it has come from 11th to 3rd position, it itself is very alarming. So we have to do, perhaps we will request Dr. Rajiv Sood, who is in charge of such a big university, to have more public health research, epidemiological research, along with all the team under his jurisdiction, as well as we are looking for now healthy aging, but I always say it is not only healthy, active and healthy aging. So we have to talk about active and healthy aging. So
Quality of life is important.
eh?
In aging, quality of life is important.
Quality of life. So let us hope that we all are aging and aging. Let us remain active and active. With this last remark, my sincere thanks to all my panelists for sparing their valuable time on Sunday. And especially, I know Rajiv, Dr. Rajiv had been traveling, and we were together in Chandigarh last yesterday, and again he is back to action. Tiwari ji, thank you very much for organizing such a wonderful
To all of you,
series
my
of webinar. Please keep it up, and to your entire staff and all your colleagues. Back to you,
thank you,
and
sir.
thank you very much
Thank
from